Hey everyone, and welcome to This Explainer. Look, if you're about to step onto the wards or sit for your medical board exams anytime soon, you already know the deal. Sexually transmitted infections are, well, they're universally tested. They are an absolute cornerstone of clinical vignettes. So today, we're going to establish a rapid-fire ward round kind of tone. We're going to walk through the absolute highest yield exam pearls from our clinical guide so you can recognize those classic diagnostic criteria from a mile away and totally crush your board exams. Okay, let's look at the agenda for today. First, vulvovaginitis and discharge differentials. Second, male presentations, urethritis and epididymitis. Third, genital ulcers, painless versus painful. Fourth, pelvic inflammatory disease. And finally, proctitis and rectal syndromes. All right, jumping right into section 1, vulvovaginitis and discharge differentials. So, when a patient complains of vaginal discharge, separating the top 3 syndromes based on their physical exam and microscopy is honestly one of the most tested concepts in all of medicine. When you're reading a discharge description on a test, you need to trigger immediate buzzword associations, right? So homogeneous white-gray with a fishy odor, you lock on to bacterial vaginosis. Profuse, yellow, and frothy, your brain needs to just shout trichomoniasis. And what about white, curdy cottage cheese? Yep, that's classic vulvovaginal candidiasis. Also, pay really close attention to the pH values. Notice that Candida presents with a normal pH, less than 4.7, while both BV and trichomoniasis thrive in a much more alkaline environment, so a pH above 4.5. On microscopy, Candida is going to show pseudohyphae on a KOH prep. Trich shows actively motile trichomonads, literally swimming around, and BV gives us those famous clue cells. For clinical diagnosis, the Amsel criteria for bacterial vaginosis relies on a strict 3 out of 4 rule. To diagnose it, you need any 3 of these 4 features: a homogeneous white discharge, a vaginal pH greater than 4.5, a positive KOH whiff test, which gives off that unmistakable volatile amine fishy odor, and those clue cells on microscopy. And remember, those clue cells are just vaginal epithelial cells that are completely coated with coccobacilli, which gives them this granular kind of fuzzy appearance with indistinct borders. It's also absolutely vital to remember that BV is polymicrobial. It involves Gardnerella, Mycoplasma, and others completely overtaking the normal lactobacilli, so it is definitely not a single organism infection. Now, if you encounter trichomoniasis, there are some really heavy-hitting traps you've got to avoid. First up, you must treat the partner. This is the standard of care to reduce the infection reservoir and stop reinfection, whereas partner treatment isn't routinely recommended for BV or Candida. Second, keep an eye out for the buzzword strawberry cervix. These are basically petechial cervical lesions that are best seen on colposcopy. And finally, here's a huge treatment trap. Intravaginal metronidazole gel is not reliable for trich. No way. You have to use oral metronidazole or tinidazole. Do not let the exam trick you into prescribing a topical gel for a trichomonas infection. Moving right along to section 2, male presentations, focusing on urethritis and epididymitis. Shifting gears to the male patient presenting with urethral discharge, the diagnostic pathways here are incredibly strict. Usually, the very first diagnostic step is a Gram stain of the urethral smear, and you are looking for one specific finding to branch your treatment path: the presence or absence of diplococci. If you see Gram-negative intracellular diplococci, boom, you have gonococcal urethritis. This requires parenteral treatment with ceftriaxone. We don't use oral cephalosporins or fluoroquinolones for this anymore because of resistance. Versus, if you have equal to or greater than 2 neutrophils per high-power field, but no diplococci on the Gram stain, you've got to treat this as non-gonococcal urethritis, or NGU. The most common culprit there is Chlamydia trachomatis, and your go-to treatments are doxycycline or azithromycin.
And you know, this logic translates directly into how we manage complications like epididymitis. For unilateral scrotal pain, the treatment flowchart relies almost entirely on the patient's age and risk factors. It's like a giant logic puzzle. If they're under 35 and sexually active, you assume the etiology is sexually transmitted, primarily chlamydia and gonorrhea. Your treatment? Ceftriaxone IM plus doxycycline. But if they're over 35, or they're men who have sex with men practicing insertive rectal sex, or maybe they've recently had urinary tract instrumentation, you've got to suspect enteric organisms, like Enterobacteriaceae. For this group, you still treat with ceftriaxone IM, but you swap the doxycycline out for levofloxacin to make sure you cover those urinary pathogens.
Okay, section 3, genital ulcers, painless versus painful. Misidentifying the character of an ulcer is hands down the fastest way to lose easy points. So let's test your own reflexes for a second. Imagine a patient presents with a single, completely painless, indurated, meaning hard, genital ulcer with a clean base. On physical exam, they also have bilateral firm but completely non-tender inguinal lymph nodes. What's your immediate diagnosis? Think about it.
Well, if you said primary syphilis, you are spot on. Treponema pallidum causes that classic painless hard chancre with non-tender lymph nodes. You've got to immediately contrast this with Haemophilus ducrei, which causes chancroid. Chancroid is, well, it's the exact opposite in presentation. It is deeply painful. The ulcer is soft with ragged edges and a purulent base, and the lymph nodes, they're painful, unilateral, and they can fluctuate, forming what we call a bubo. An easy way to remember: syphilis is painless and hard, chancroid is painful and soft.
Now, there is a massive diagnostic trap waiting for you here. Up to 30% of primary syphilis chancres are initially seronegative. Let me say that again. 30%. That's almost a third. If you have a high-risk patient presenting with a classic painless chancre, do not, I repeat, do not let a negative early RPR or VDRL blood test falsely reassure you. The antibodies just haven't developed yet. You either need dark field microscopy right then and there, or you absolutely need to repeat the serology in 1 to 2 weeks. Looking at the remaining key ulcer differentials, we have to contrast herpes and LGV. Herpes, or HSV, is the most common cause of genital ulcers worldwide by far. It far exceeds all other causes. It typically starts as painful vesicles that rupture into multiple shallow ulcers, and a super key history point is recurrence, versus LGV, which is caused by Chlamydia cervars L1 through L3. The initial ulcer here is small, painless, and honestly so transient that the patient usually misses it entirely. What actually brings them into the clinic is what happens next: a marked, dominating, painful inguinal bubo that creates the classic groove sign separated by the inguinal ligament.
Moving on to Section 4, pelvic inflammatory disease, or PID.
Pelvic inflammatory disease is an ascending infection with incredibly high stakes, so the diagnostic threshold is notoriously low. You absolutely do not wait for lab cultures to come back before treating. To start empirical treatment in a sexually active young woman with pelvic pain, you need any one of the following minimum criteria on physical exam: cervical motion tenderness, uterine tenderness, or adnexal tenderness. Just one. Honestly, you want to err on the side of overtreatment here just to prevent irreversible tubal scarring. It's actually kind of amazing to look at the public health impact of catching these pathogens early. Check this out. There is a massive 56% reduction in PID incidence achieved simply by performing annual chlamydial screening on sexually active women who are 25 years old and under. This is highly recommended by the CDC for exactly this reason: to intercept these infections before they can ascend. The data behind this, which comes from a very frequently tested landmark Swedish study, shows how the risk of infertility compounds devastatingly with every recurrent episode. After just one episode of PID, the infertility rate is 11%. After 2 episodes, it jumps to 23%. And after 3 or more episodes, a staggering 54% of patients will experience infertility. On top of that, just having a history of PID increases the risk of an ectopic pregnancy by 7-fold and the hysterectomy rate by 8-fold. It's a huge deal. Finally, we arrive at Section 5, proctitis and rectal syndromes. Focusing on gastrointestinal mimicking presentations, particularly in men who have sex with men, first up is LGV proctitis. This is a severe rectal infection that presents with anorectal pain, tenesmus, fever, and perianal ulcers. But here is the massive exam trap. If you take a rectal biopsy of LGV proctitis, it shows granulomas, giant cells, and cryptopsises. This perfectly mimics inflammatory bowel disease, specifically Crohn's disease. You must always run NATs or serology for LGV before diagnosing new-onset IBD in this demographic. Otherwise, you might subject them to lifelong immunosuppressants for what is actually just a curable 21-day doxycycline infection. We also really need to differentiate 2 highly specific exam pearls in this category. If the vignette describes a patient with proctitis who suddenly develops neurological symptoms like urinary retention, constipation, or anal sphincter laxity, that is HSV proctitis causing a sacral nerve root radiculopathy. Versus if you have a sexually active male without HIV presenting with enteritis rather than proctitis, so disease higher up in the GI tract, the most common sexually acquired culprit is actually the parasite Giardia lamblia. Wow, okay, we've covered a tremendous amount of ground today, from vaginal pH thresholds to differentiating painful versus painless ulcers and recognizing the catastrophic compounding risks of PID. When you're sitting in that exam room and see the next vignette pop up, ask yourself, can you confidently distinguish a surgical emergency like testicular torsion from infectious epididymitis? Can you tell a simple, curable ulcer from one that signals a lifelong complication? Trust the clinical criteria we uncovered today, stick to the buzzwords, and you are going to navigate these questions with total confidence. Thanks for joining this explainer, and good luck on the wards.